The notice that we shared with the National Hospital Insurance Fund, which has transitioned. Most of the issues are under the Social Health Authority now. So the AGM this afternoon will decide based on the interactions today. We'll decide as to whether the notice that we issued to the NHIF still is in place, or whether providers want to have a different consideration. As an association, we are still in talks. We have a lot of commitment, and as you can see, a lot of commitment from the highest levels of government. But essentially, providers probably need to see a bit more. They need to see a plan for settling the bills, a plan for payment, and we will be discussing that during our AGM in the afternoon. And the resolution that comes from that AGM will be binding on the members. So as it is this morning, the notice is still in place, but the purpose of this meeting is actually to see whether we can have a different way forward. Some of the figures are public. We know that, and I hesitate to speak with the chairman here, but I think they have been very transparent. On the books of the Social Health Authority, it's a figure like 22 billion outstanding. We would like that entire figure settled before the Social Health Authority takes over. And if you look at the timelines we are talking about 30th of June. So what we need is commitment from government, that is the National Treasury essentially, to settle these outstanding liabilities of NHIF by June. We want the Social Health Authority to start on a clean slate. We do not want the Social Health Authority to carry forward historical debt from NHIF. I don't know, Chairman, do we have timelines? What I know for sure is that there is commitment, and I think we're on the same page, that before the transition is over, the settlement of claims must happen. But a lot of providers have gone for many, many months without substantial payment. So what we as an association are asking for is some sort of immediate relief that is substantive. Now, immediate relief that is substantive may be 50%, maybe 60%. That is subject to our AGM this evening. And whatever resolution comes out of that, we will be happy to communicate to the authority and say, even as we negotiate and we talk to National Treasury on our behalf, really, this is really the minimum we can accept to alleviate the pressure that is there in the health system.
We are working with all players in the sector to ensure, however, that because internship is a prerequisite for registration, for one to be called a doctor who can be able to practice medicine, that we put in place measures to ensure that all graduates from our training institutions undergo the mandatory internship program so that they can be registered to practice as doctors. We will work with the private sector. Already, some private sector institutions have been internship centers, the likes of Aga Khan Hospital, the likes of Kijabe Hospital, and we are going to bring more on board, working together with the regulatory authority, the Kenya Medical Practitioners and Dentist Council. We are doing passive surveillance from our surveillance sites. The numbers so far are not anything to worry about, and we believe we have built a health system that is resilient enough, robust enough, strong enough to be able to overcome any variant that COVID will throw at us. So we are watching the space, but nothing to worry about for now in terms of the numbers.
Under NHIF, they had got a lot of so-called enhanced schemes. An enhanced scheme implies that you have got an employer, for example, deciding to get additional benefits over and above the package that was being offered in the national scheme of NHIF. So the new act as it is shackles us in terms of we are not going to be running any enhanced schemes. That is because we want a standard package which we can communicate, which will be the same for everyone. So there will be one benefits package. So as it is now, the police, as you mentioned, and so on, are not with the National Health Insurance Fund, and going forward, there will be no enhanced scheme. So anybody looking for an enhanced scheme will have to procure those services through a different insurance provider. How about insurance penetration? You know, we've got three dimensions of universal health coverage. And I'm going to say three dimensions, the breadth in terms of how many people are covered, right? Now, what the intention is, through the UHC initiative, we're going to make sure that more people are covered so that we pre-finance healthcare and people don't have to pay for healthcare service at the point of service. So, through UHC, we are saying, first of all, we need to make it mandatory. And this is one of the things that people have got a real issue with. And you know anything when there's change. But you understand the logic is, if it's social health insurance, first of all, we have to have most people have to be covered. Otherwise, the business model does not work. So this is where the section 26(5), which is what is being challenged in court, came about. Because how do we make sure that people pay? I don't think we're going to be arresting people in the street and asking, do you have an ID and do you have the social health insurance card? And if you don't, we take you and lock you up. I don't think that will be a very popular way of doing it. So what they thought about was saying, before you access other government services, use it as a point to be able to ensure people enroll. I know it is something that is controversial and I won't delve into it because it is in court, but I would challenge anybody else to tell us how else do you think we can enforce this. Because, for example, when we go to the bank and want to open an account, they tell you these are the requirements. You give us your ID. If you don't have one, they send you to NRB to get an ID. If you don't have a PIN, they send you to KRA. I don't know whether that is constitutional or not, but that is for you to decide. But there has to be a way in which we enforce this. Then, paying for indigents and those who are vulnerable, the government has said that anybody who is genuinely unable to pay should have the premiums paid for them. Then the benefits package has been expanded, and that's the intention. And it's been expanded, and that is about the scope of the services that we're going to be offering. So that's the depth dimension of UHC. And then increasing the proportion of benefits covered. Catastrophic health expenditure most of the time comes from chronic illness, critical illness. I've never seen anybody go broke or become indigent because of having malaria, especially if it's a simple case. So the chronic illness and critical illness was a component, and that's why the Emergency Chronic and Critical Illness Fund was introduced. So again, we're increasing the proportion of benefits covered so that if you're under the Social Health Insurance Fund and you exhaust your benefits, then we move you on to the Emergency Chronic and Critical Illness Fund. Now, in terms of operational efficiency at NHIF, the Act says only 5% of whatever revenues are received, I'll use the term revenues, can be used on administrative costs. So there's a cap on that, and that is actually a very tight margin, because I think at the moment we are still at the range of 10-12%. So that means there's going to be a lot of cuts in terms of administrative expenses. Then the Act also mandates us to periodically engage stakeholders in an organized manner. And I'm saying stakeholders mean the general public, in addition to stakeholders like yourselves. And then there's the aspect of technology to digitize the process, to make our processes more efficient. And then there's talk about reconfiguring healthcare provider compensation mechanisms to be more aligned with the objectives of UHC. I've talked about having one standard scheme and abolishment of the enhanced schemes. And then our fraud detection and fraud prevention systems just have to be stepped up, because one of the ways of deterring fraud or engaging in fraud is that it's always an economic motive. And if we can get to a point where people don't get paid for fraudulent behavior, it will just kill it. In fact, if anything, it will cause even bigger problems, because somebody will say, somebody else, I did this for you and I didn't get paid. So that's the only way to kill it, because once the money has been received, these efforts at recovery and prosecution, much as in the event the system doesn't detect it, we will do that, but that's not the objective. It's to prevent the fraud in the first place. A lot of the functions that we had at NHIF, I've talked about accreditation. This regulatory function has been moved to other regulatory bodies. So, for example, KMPDC at the moment is the one that accredits, in terms of accreditation of facilities, is involved in that. Empaneling and contracting will still be a role of the NHIF, managing the funds, but claims management has been put again in a specific office. And there's a lot of controversy, I know, around the issue of outsourcing some of those functions. And I'd like to say the anxiety is understandable, but I don't think it is necessarily warranted at this point. one of the things that was put in place during public participation was the Act had said the Social Health Authority shall outsource certain functions. Later on it was amended to may. So now it is not obligatory, it is discretionary, right? And it will be discretionary and it will only be done if it is one of those where somebody can do it more efficiently and is going to impact positively on our costs. Now, there are a lot of concerns about the issue of zoning of the different areas, and we were zoning the country with a view to minimizing the risk and enhancing efficiency amongst the different providers. However, the reasoning is this: if we had only, especially we're going to be heavily IT oriented in the new arrangement, and we're only going to have to verify claims for a small percentage as opposed to the large number we're doing currently, then we don't need as many boots on the ground in terms of people who are QAs covering a region. Otherwise, you might have somebody moving from TC to see one case to verify that there's one case that was flagged by the system. Then you have to spend the rest of the day traveling to Migori and so on. So why don't we use companies who already have these resources on the ground and use them to verify that for us? That is the reason. But that is a decision that we will make as an authority when we get there. So in terms of leadership, the constitution of the board was very well thought out and defined in the Act. And that's why I'd like to say, for the first time, I think, we have got four doctors on the NHIF board. And in addition to that, we've got significant representation. The Director General of Health, and Dr. Moth, welcome, I acknowledge your presence. The Director General of Health, we have representative from the PS Treasury, the PS Ministry of Health is also represented, and at the moment he sits there in person. Then we've got representatives from different sectors. So I think the representation from the stakeholders is solid, and that's why even healthcare providers have got an appointee on the board. So in terms of taking care of stakeholder interests, I think that is taken care of. Then for us to be able to mitigate in the terms of resource disparity, I think indirectly by injecting resources into the regions. So now we are sending funds to the periphery because we'll provide care level 2-3 facilities wherever they are found, but also the facility improvement financing bill ring fences funds, especially for public facilities, to make sure those resources don't escape from there. Because in the past what has happened is the resources are sent there and payments are made, but again they end up building roads, doing some other things. So in terms of bringing down healthcare costs, we have brought down healthcare costs. We plan to bring down healthcare costs, first of all, by these investments we're making in primary healthcare, but we need to be able to rationalize that healthcare commodity supply chain, if it's through bulk procurement, if it is through increasing local manufacturing, and I'm glad some of the local manufacturers are here, because that is a very significant component of the healthcare costs. And it would be better for us to be able to keep these resources locally as opposed to spending tons of money going out of the country. So the NHIF Act could not be amended to accommodate all these changes. So it was easier to sit down and draft new legislation, and especially because of the wider mandate, we had got a primary healthcare fund which is funded by the Exchequer, and the Emergency Chronic and Critical Illness Fund, which are new components. And then you've got the Social Health Insurance Fund, which is the equivalent of what NHIF was. And that is why the Social Health Insurance Act, the Primary Healthcare Act, the Digital Health Act, and the FIF Act came into being. And SHI, so the Social Health Authority was born, where we have got these three funds. If I was a preacher, this is the point when I say, do I hear an amen? So in summary, the problems we had in our healthcare system were clearly delineated, and we all knew them. The conceptualization of the Social Health Authority and these acts was ideologically aligned to UHC. We had it anchored in legislation so that it's not purely policy guidelines, it is law. The team that was assembled, starting with the board and what we intend to assemble, is going to be a team that is competent. And under my leadership, I can assure you, implementation is going to be disciplined.